Hey everyone, my name is Ashley Babin and I'm the inpatient rehab speech therapist at Baton Rouge Rehab. I've been at Baton Rouge Rehab for 5 years now, but I've worked with the adult population in the hospital setting for about the last 9 years. Today I'm going to talk to you about cognition, especially after a brain injury. It's a term we use here a lot in the rehab setting, but what exactly does it mean? So hopefully today you'll leave with a better understanding of all the many different components to cognition. There's no single agreed upon definition of cognition. Cognition is a complex collection of conscious mental activity such as attention, perception, comprehension, memory, and language. At Baton Rouge Rehab, the speech therapy team tends to assess and treat disorders of cognition related to attention, memory, orientation, problem solving and reasoning, executive function, insight, and safety awareness. These subskills are very complex, so let's break them down one by one. When we think about cognition, there isn't necessarily a distinct one-on-one relationship between function and location within the brain. Cognitive function is widely distributed across many regions and structures of the brain. Certain functions, however, are localized within certain lobes of the brain. Let's take a stroll back through neuroanatomy and review some of those lobes and their functions. The frontal lobe is especially important for cognitive function because it develops and activates plans as a result of input from all the other lobes of the brain. The frontal lobe is responsible for attention, motivation, emotional, social, and behavioral control, verbal expression, judgment, spontaneity, problem solving, sequencing, decision-making, and expressive language. The temporal lobes are responsible for emotional responses, face recognition, language comprehension, memory, object categorization, object location, receptive language, and selective attention. The parietal lobe is responsible for tactile perception, spatial orientation, academic skills, object naming, visual attention, and hand-eye coordination. Visual stimuli processing is the primary role of the occipital lobe of the brain. Again, it's important to remember that because of the complex nature of cognition, the individual components aren't necessarily isolated to one area, but rather function as a wide network throughout the brain. One of the components of cognition is attention, which can be broken down into 4 levels. Sustained attention is the ability to maintain attention to complete a task accurately and efficiently over a period of time. This is the first level of attention required to proceed to the next level of attention. Selective attention is the ability to maintain attention in the presence of competing distractors, such as background conversations or sounds. This might include paying attention to the therapist talking while other background conversations are taking place. Alternating attention requires the ability to shift focus between tasks, such as between steps of a recipe or working as a receptionist who has to answer the phone and respond to visitors at her desk. Divided attention is the ability to respond simultaneously to multiple task demands while maintaining speed and accuracy. This is the highest level of attention and might include functional tasks such as driving while talking on the phone, or cooking multiple items at the same time, like having a pot of boiling water on the stove to cook noodles, a roast in the oven, and burgers on the griddle. Attention deficits are common in patients with acquired brain injuries because the attention network is widely distributed throughout the brain and is easily disrupted by injury. It's important to understand where your patient's attention level is at the time of treatment to know how to modify the environment to their needs or how to increase challenges in the environment to challenge their attention skills. Now that we have a better understanding of attention, we can see how attention may affect a person's ability to recall information. Only information that is present and attended to at the time of encoding can be stored, and only information that's stored can later be retrieved. Research shows that patients with moderate to severe brain injuries can still be able to recall new information just at a slower rate compared to non-injured control subjects. Just like attention, there are various levels of memory. The first is immediate or sensory memory. Sensory memory holds information for a few seconds immediately after the item is perceived. This information can be absorbed from all 5 senses: vision, hearing, touch, smell, and taste. Moving into the next level of memory, short-term memory, is the ability to recall information after a few minutes up to hours later. So the time frame increases here compared to immediate or sensory memory. The next level, long-term memory, involves permanent consolidation and storage of information, often lasting a lifetime. These memories can be retrieved years later, despite the initial event happening well in the past. This is the longest duration of memory. The speech therapist works with patients on improving these levels of memory, but you can see how the carryover can occur throughout the day by having other members of the multidisciplinary team quiz patients on trained information that was presented during therapy sessions. Sometimes speech therapy may initiate an external aid to help the patient with recall of information at the short or long-term level. These might include items such as a memory notebook, a timer, an alarm, etc. Everyone should assist patients with utilizing these aids outside of therapy to help with carryover of these compensatory strategies. Moving on to the next element of cognition, orientation. Orientation is probably the least complex subskill to break down. In medical terms, you'll often hear something like alert and oriented times 4, referring to 4 elements of orientation: personal, temporal, place, and situation. Personal orientation refers to information specific to the patient, including their name, date of birth, age. Temporal orientation refers to the patient's understanding of where we are in time. This includes the year, month, date, and day of the week. Place obviously refers to the current location of the patient. Finally, situation refers to understanding of what happened to the patient and why they are in a rehab facility, even if just at the surface level. You'll learn that at certain ranchos levels, it may not be appropriate to quiz a patient on this information, and is it instead better to just provide the information to the patient until they are able to encode it for later recall on their own. Problem solving and reasoning are a complex group of abilities. We refer to nonverbal versus verbal problem solving and reasoning at times. Sometimes a patient with an acquired brain injury will present pretty high level at the verbal level, but break down at the nonverbal level. For example, the patient may be able to verbalize the coin amounts needed to total 73 cents. But when set up with a pile of coins and asked to tangibly pull coins out to make the 73 cents, the patient may have difficulty. Another example may be a patient verbalizing that they know how to organize their medications and take them properly. But when set up with a medication management task involving manipulatives like fake pills and a weekly pill organizer, they break down and cannot complete the task accurately. Also included in this subset of skills is mathematical skills. This encompasses not necessarily the ability to spit out math facts, but to use math functionally to figure out how to manage money, budget, etc. All right, moving into the next level of cognition, one term you'll hear in the brain injury world has the actual term cognition in it, and it's called metacognition. This is the same ability that we often call insight. This involves the ability to self-reflect and internalize awareness and control over your behavior. For example, a patient may know they are having trouble moving their left leg, but they may still think they can stand and walk to the bathroom. Patients with acquired brain injuries often have difficulty realizing their deficits, difficulty realizing the functional implications of these deficits, and an inability to set realistic goals. This is a dysfunction of insight or metacognition. Safety awareness really piggybacks off of insight. When patients don't understand the realistic and functional implications of their impairment, they may still try to do things that they probably can't. Like the previous example, a patient may know their left side is weak, but may still get up and try to walk to the bathroom on their own. The patient knows they have a physical problem, but cannot integrate this knowledge into their thought process to make safe decisions. Sometimes the patient may verbalize the correct answer like, yes, I know to use my call light to get help to the bathroom. But then later on, you may hear the patient's bed alarm going off because they're trying to get up and walk to the bathroom on their own. This can be a frustrating situation for staff, but understanding that the actions are the result of the brain injury and cognitive dysfunction rather than stubbornness or refusal to follow processes can help you to better isolate the action from the patient himself. Okay, moving along here, we're almost done. Y'all are doing great and learning so much, so give yourself a pat on the back. Executive function is probably the most complex of the subskills of cognition. It's sometimes referred to as the conductor of the orchestra. So think about an orchestra and how it involves several musicians and instruments all playing separately but together to create a uniform, organized sound. In the same way, executive function is the ability to control and manage all of the components previously mentioned in order to initiate steps of an activity and carry out the remaining steps. It's the ability to understand the ultimate goal of the task that you're doing and the sub-steps of how to get there. It includes the ability to organize steps and sequences to carry out tasks in order to plan and make decisions. It's the ability to monitor yourself and your performance, including the ability to identify errors and know how to correct them and revise a plan for the future. It's the ability to manage your time and plan to know how to complete tasks in a timely manner. Essentially, it entails the ability to operate as an independent adult. As healthcare professionals, we operate at a high level of executive function each day to manage our caseloads, changing our schedules and daily plans, adapting to our patients' needs, and making quick decisions with sometimes limited information. Patients with acquired brain injuries may exhibit impulsivity or the inability to think before they act or move. They may be overly talkative, not be able to stop a certain behavior from happening, or not be able to filter their inner thoughts from being verbalized. While a patient may do very well in the structured confines of the hospital, deficits can become apparent outside of established routines and expected events. You'll learn how progression of daily activities and therapeutic tasks may involve changing the patient's environment or taking the patient on an outing to really challenge or test their executive function skills. Given the global encompassing of all the abilities above, you can see how executive function deficits may be apparent at all injury severity levels and across several aspects of daily living. So now that we understand the various components of cognition, how do we know if a patient is having cognitive deficits? How do we know where to start? At Baton Rouge Rehab, the speech therapist will conduct a formal assessment of a patient's cognitive skills as appropriate. There are a variety of standardized tests to pull from, but you'll commonly see the speech therapist use the Montreal Cognitive Assessment, or the MoCA, the St. Louis University Mental Status Examination, or SLUMS, and the Cognitive Linguistic Quick Test, or CLQT. Just like we know assessment can include our professional clinical judgment, it is best to also assess using a standardized tool that has been normed and is sensitive to identifying areas of impairment. It can also be used as a way to measure progress in therapy by comparing pre- and post-therapy test scores and as an outcome measure to provide to payer sources. The last area that I do want to point out involves other factors that can potentially influence cognitive function that we also need to consider in addition to results on a cognitive assessment. Some of those might include hearing ability. Does your patient have hearing loss? Do they have hearing aids? If they do, is the patient wearing them, or do they need new batteries? This can greatly affect a patient's response to cognitive tasks if they cannot hear you. Vision, likewise, is another sensory component to consider. Does the patient have premorbid visual deficits? And if so, do they have the corrective lenses or eyeglasses with them? Has their vision changed as a result of the acquired brain injury? If a patient cannot see the nonverbal reasoning task, for example, drawing a clock, given to them by the speech therapist, they won't be able to appropriately respond to it. How has their medical status been? Changes in medical status can affect the patient's energy levels, mental endurance, and response to tasks. Furthermore, does the patient have a history of pre-existing psychological factors that affect their ability to participate in therapy. A new acquired brain injury can very often cause emotional dysregulation and impaired behavioral control as well. What access to resources did the patient have prior to the injury? How much cognitive functioning did the patient have to do before the injury? The care plan for a patient who had family members manage their medication, finances, cooking, and transportation would look much different than a care plan for a patient who was working full-time and independent with all of those skills. We should also consider, are there any premorbid language learning disorders like auditory processing disorder or dyslexia or attention disorders like ADD, ADHD? Lastly, how much formal schooling did the patient complete? Goals may be different for a patient who completed a doctorate program at the college level compared to a patient who only attended school up to the 9th grade. These are always on the speech therapist's radar as possible influencing factors to cognitive functioning. That wraps everything up. Thank you so much for your time and attention today. I hope you have a better understanding of the global term cognition and how many complex processes it involves. It's important that every member of the team, not just the therapist and nurses, have a clear understanding of the various cognitive deficits our patients may encounter after brain injury, so we know how to structure our tasks, conversations, commands, and even expectations to ensure we aren't overwhelming our patients. It's also important to understand that sometimes problematic behavior, such as frequently getting out of bed, can be a direct consequence of impaired cognition and a result of the patient's injury, and not a reflection on how the patient feels about your authority or instructions. Working with patients with brain injury can feel challenging at times, but assisting patients to overcome these deficits and return to their families, their jobs, their schools, and their communities makes it all worth it. Remember that Baton Rouge Rehab has a team of speech therapists who treat these disorders of cognition, so please use them as your resource if you need any guidance with the acquired brain injury population. I've listed their names on the slide here, and they include myself, Lori Wilson, Ann Burns, and Kim Diaz.
Baton Rouge Rehab Hospital is proud to be a leader in inpatient and outpatient rehabilitation services in Baton Rouge and surrounding areas. We pride ourselves on a commitment to restoring lives through compassion and a dedication to excellence. As the frontline staff members at Baton Rouge Rehab, we achieve these goals and standards through a responsibility to attain the highest level of competence and consideration for the unique and specific needs of our patients. Participating in hospital-wide education and seeking out opportunities to learn and grow as an individual is what can set you apart as a top talent contributor to the hospital. The education provided to you today highlights the 4 values of Baton Rouge Rehab: compassion, integrity, teamwork, and excellence. When you take the knowledge you have gained and apply it to person-centered, excellent care, you are contributing to the excellence of Baton Rouge Rehab. Thank you for your dedication.